So don't worry, everything can be applied as an adult. So this was a 12-year-old girl who was brought by her mother, who the mother complained of excessive sleepiness. I think I should leave it here.
Okay. An interesting.
I think Amani is in a very noisy place. Can you maybe if your life's home and
Yeah, yeah. So
continue?
so I think I'll just start, and then Amani, once you are home, maybe you can just drop a text
Sure.
in the chat, and I will continue. So I will start with this one. So someone who presents with excessive sleepiness. Well, I tell you, I think I do not have a very good schema when it comes to sleepiness. There's just a number of differentials that I have in mind, and therefore I think those will be all that I have for today. But if someone presents with excessive sleepiness, so I'll just make up something as I proceed. Um so excessive sleepiness. So the way I'll think about this, and I'm not sure if this is something that exists. So when I tell you that I'll make things up as I proceed, I mean it. I would say that if someone presents with excessive sleepiness, I will try and make up a categorization that I may categorize it into two. That maybe it's a primary sleep disorder, if there is anything, if really there is anything like that that exists. So examples, when I mention that, and I think I'm loosely using terms here, but so there are things like narcolepsy. That is one thing. Narcolepsy, for example, so it's a sleep disorder, and there are types of narcolepsy. I do not even know the difference between the those types, but I think there is a narcolepsy, maybe type 1, type 2. I've read about them in the past. And there are some other also sleep disorders. So I'll say those are like primary, and then secondary is someone presents with excessive sleepiness, but it's because of something else. So for example, someone with obstructive sleep apnea. With obstructive sleep apnea, because someone does not have good sleep in the night, they do not have deep sleep because of the apnea that they experience, and therefore they wake up many times. So they do not get that deep sleep, and therefore during the day they will be napping a lot. So I would consider that to be secondary. And so apart from obstructive sleep apnea and maybe other sleep disorders, so all sorts of sleep apnea. And another one is someone who is having insomnia at night due to some reasons, maybe sleepy during the day. So you're having insomnia during the night. So again, another sleep disorder. So there are sleep wake cycle disorders, like someone who has an advanced sleep wake cycle disorder. So there's someone who is sleepy during the day. So it's like the circadian rhythm is disturbed, and therefore they are early to sleep, for example, and they wake up late. So it's like your sleep clock is messed. So you are awake during the night, you are asleep during the day. Or it may not be perfect like that, but let's say you sleep earlier than other people, and you wake up earlier than other people. So that would be another possibility. And then systemic illnesses like hypothyroidism, for example. So hyperthyroidism presents with insomnia, hypothyroidism. These people can be napping a lot. So think of many endocrine abnormalities which can present with excessive sleepiness. So I think that is a very rough sketch, but I will I'll approach it that way. So Joseph, let's proceed with the history, and I'll see what I can come up with, but overall, I think this is a tough one.
Yeah, that's a very good made up approach. So let's see. Uh, so the mother reported that over the last 3 years, her daughter has been having episodes of excessive sleepiness. These symptoms persist for weeks to more than a month and then disappear. And then she returns back to her normal wakefulness, but reappears again after some time. It was noticed for the first time when she was in boarding school and she couldn't stay awake in class. So it was thought maybe it's the boarding school. She was moved to a day classes, but the problem still persisted. When the symptoms start, she would wake up 4 hours later than her usual waking hours when she's not going to school. And on school days, it is so hard to wake her up to prepare for school. She sleeps in school bus, she sleeps in class. After school, she'll sleep for most of the evening. And unless she's woken up for dinner, she'll sleep up until the next day. On the day she's in a normal state, she wakes up at 6 a.m., she prepares for school, she chats with friends in the school bus, and she chats with her mother when they're coming home. And at home, she does homework, she watches TV, and she sleeps at 9, 10 p.m. But mother denies, the patient denies hallucinating just before sleep and after waking up. She also denies a sense of total paralysis when about to fall asleep or just after waking up. The mother denies that her daughter snores at night or abnormal limb movement that she sees. The mother also reports that she is not anxious for no reason. There is no abnormal behaviors, no previous traumatic events, or abnormal changes of mood. There's no headache, double vision, focal neural deficit, abnormal limb movements while asleep or awake, or tongue biting. There is no previous of history of head injury. Yeah, that's HPI.
Okay, yeah, interesting. I see you touched on some of the things that I mentioned and some things that I wanted to mention, but then because my mind was racing, I forgot some of those. So yes, another one is, for example, periodic limb movement. What do we call that? Yes, I think so. There is a restless leg syndrome that also can lead to. So basically, restless leg syndrome, it's like it causes an equivalent of insomnia at night, and therefore during the day someone will be sleepy. It's because they are not having deep sleep at night. And I should admit that I think sleep medicine or sleep in general is one of those things that I've just brushed on. It's a very interesting subject because so the issue of random eye movement and then non-REM sleep and all those things, very interesting stuff. But because I do not encounter these patients many times, I haven't been going back to it frequently. So yeah, I think most of the things that I have is superficial knowledge. But so there's I was talking about restless leg syndrome, or and I think there's another one called periodic limb movement disorder. So these are disorders of sleep or parasomnias, which basically it's like someone is not having enough sleep at night, and therefore during the day they are very sleepy. Another one Joseph was talking about experiencing hallucinations uh, when falling asleep or when waking up. So there's hypnagogic and hypnopompic hallucinations. So she doesn't have those. Yeah. So what I see here is some of the things that I talked about and some of the things that I was thinking about are not the case in this patient. So restless leg syndrome is not an issue here, or periodic limb movement disorder is not an issue. Uh, I was talking about obstructive sleep apnea. Joseph said there is no snoring, no nothing, and then these other parasomnias, hypnagogic, hypnopompic hallucinations, nothing. And then what else? Yeah, so anything purely neurological that can be associated with the sleep disorder. So, for example, again, people can be very sleepy or can have insomnia when they have mood disorders. So mood disorders like particularly depression, major depressive disorder. With major depressive disorder, because someone is losing interest in activities, so that could be one of the symptoms that someone is oversleeping. Others are experiencing insomnia, others are oversleeping, and therefore we do not see anything in keeping with a mood disorder here. Uh, because whenever she's not sleepy, we see that she's engaging with she's engaging with other people normally, whether it's her mother or peers at school. So I do not see anything that is in keeping with the mood disorder, like major depressive disorder. Of course, with something like bipolar disorder, someone would be sleepy when they are in the low. That is when they are experiencing a depressive episode. Because we know with mania, someone is not sleeping. So I do not see anything that is pointing in the direction of a mood disorder. And another thing, someone can have insomnia and therefore maybe sleep during the day because of post-traumatic stress disorder, but we hear that there is no history of a previous traumatic event. So I think I've been revolving around mood disorders for a while. So other things are when you have an organic neurological issue. So, for example, some seizure disorders or syndromic seizure disorders can come with sleep abnormalities. This patient doesn't seem to have any seizure disorder. And so, when there's an organic thing like, although now unless, so theoretically speaking, if there's something organic or a mass uh, in the reticular activating system, and I do not know which other symptoms would come up, but maybe someone would experience issues with maintaining wakefulness. But we hear that there are no focal neurological deficits. So again, nothing very neurologically convincing. No mood disorder that we see. Some of the sleep disorders that we're talking about, especially obstructive sleep apnea, periodic limb movement, restless leg syndrome, some of the hallucinations that I mentioned, which can be associated with these sleep disorders, are not here. Although, so I talked about some endocrine issues, so particularly hypothyroidism. We do not see anything that is in keeping. Of course, no. Although I do not see maybe Joseph asking or inquiring about some symptoms that would point us in the direction of hypothyroidism, whether there is a weight gain, constipation, uh, general psychomotor slowing. Uh, but the fact that they are not here, I'm assuming that this patient did not have those, or when we hear the review of systems, we'll see if there is anything that is pointing us in that direction. So I think a lot has been ruled out. I remain with a few, which again, my knowledge about those few that are remaining is very, very limited. I happen to read about them, but because I do not encounter them frequently, the memory is fading. So, Joseph, let's proceed with other components and I'll see if I can make any progress.
Yeah, I can tell you my knowledge was more limited than yours when I saw this patient. Yeah, so review of the system is so unremarkable. Past medical and surgical history, she had adenotensilotomy at the age of 6, no complication. Family social history, she has a very good school performance. Her mother has 3 girls, the rest are in good health. She was born by SVD. There was no complications around the period of birth. She received all childhood vaccinations, and there was no major childhood illness. And
Yeah, I think there is nothing very new, but the fact that a performance at school is good. We do not see any family history, and then no major childhood illnesses. Uh, so what this tells me is it could be something. It's basically an isolated sleep disorder uh, rather than a small part of a big syndrome. Like for example, if she's having uh, psychomotor retardation in general, global developmental delay, we do not see anything of that sort. So I see this. I think what this tells me is that it's an isolated sleep issue rather than something syndromic. But I'll see as we proceed if I can change my mind in any way. So let's see the exam.
Okay. So, general exam. When I was taking the history from the mother and the child was so sleepy. She couldn't stay alert for history taking for more than 5 minutes. She would fall back to sleep on my table. And she was a febrile. She was not pale. She didn't have jaundice. Her vitals were in normal limits. Um, Performed a simple neuro exam, which was completely normal at that moment, except for the sleepiness. And other systems are also normal. So I did also some labs, full picture, MRD, TRBG, urine analysis were all normal. Creatine BUN, thyroid that we're inquiring was also normal. Liver enzymes and electrolytes were all within normal limits. And this short case, I think if you have a diagnosis, you can give me.
Okay, so I see Roland sent something here. Let me quickly. Yeah, so trypanosomiasis. Yeah, so thank you, Roland. I think that's a very good point. Trypanosomiasis, and again, I'll tell you. I think I the last time I read about trypanosomiasis, it was probably in the basic sciences when I was doing my undergraduate education. It's been a long time, and I think with trypanosomiasis, as you said, we would expect some prodromal symptoms, and of course, so trypanosomiasis is basically so it's an infectious disease, and there are some flies. I do not remember the exact name of the flies that will bite a person and therefore transmit the pathogen, and then someone will start with some prodromal symptoms, and then later on sleepiness comes. But then, so the issue is, I'm not sure with our in our setting, whether our country is endemic to trypanosomiasis. And I would say, so the limited knowledge that I remember, thank you, Brendan. So flies, uh, the so the areas which are endemic generally would need those areas. I think it's in pastoralist societies, particularly in pastoralist societies, uh, and so exposure means someone who has been bitten by those flies. Then they would present with some prodromal symptoms, and then the sleepiness comes in. Yeah, so with that, so the absence of prodromal symptoms, I think that speaks against it. And but that's a very good point to raise, and I think just to make sure that I refresh on my knowledge, I think that's another thing that to go and read about. And yes, some important issues that are being raised in the chat. Yeah, so drugs, alcohols, very good points to raise. So when you talk of drugs, we know that there are medications, even medications, and I think that's another thing that when I was talking about that sleep disorders, when someone is sleepy, the category of secondary, so basically drugs should go in there. And examples of so when you talk of benzodiazepines, for example, we know that benzodiazepines are sedative. So you can talk about sedative medications like benzodiazepines, Also antipsychotics. So generally talk about these medications, tricyclic antidepressants. We know that they cause, they sedate, like amitriptyline itself is sedative. Medications that are used for neuropathies or uh, for anti-seizure medications, pregabalin, gabapentin, and many anti-seizure medications can have a sedative effect, and therefore medications are an important issue to consider. Joseph is telling us she's not on any medications. So drugs of abuse, yes, alcohol is a sedative. Opioids, so opioids talk of heroin and people who are abusing medications like so the opioid analgesics, they also have a sedative effect. So those ones can also cause sleepiness. Again, this patient does not have is not on any medications. So I'll go back now. This is a 12 years old female with an unremarkable childhood. So normal developmental milestones, and she's performing well at school. And whenever she's not on on the episodes of excessive sleepiness, she engages normally at home and at school, and her performance is good. She presents with periodic, so on and off episodes of excessive sleepiness, but then uh, no other neurological symptoms, no other systemic symptoms. She's not on any medications, no history of trauma, no history of chronic illnesses. Yeah, so obstructive sleep apnea, Joseph told us that snoring was not picked, but I think when it comes to examination, maybe Joseph would have told us if this girl is obese or overweight, and to also examine the oral cavity and see and determine the Malampati score. But generally, so I'm assuming that because Joseph told us that there is no snoring, probably obstructive sleep apnea is not an issue here. So another thing that is, I think that I'm failing to answer is the on and off history. But at this point, I would say that this is in the broad category of primary that I was talking about, because I do not see anything secondary. So with secondary, just to recap, I've talked about and I was reminded about medications and drugs of abuse. And another issue is the other sleep disorders that I've already talked about, and then mood disorders, which do not seem to be the case here, primary neurological disorders, which do not seem to be an issue here. With regards to endocrine, I talked about hypothyroidism, and I believe there are some others. So, and Joseph told us that electrolytes are normal, because you'd think that someone who is failing to maintain wakefulness. Generally, when you think of electrolytes, you think about something like sodium, particularly. Potassium is not very much involved here, so it's an issue of sodium. So you see sodium normal, so issues like adrenal insufficiency, for example, which mainly presents with if it's an issue of dizziness, and then someone can go into coma when they experience an adrenal crisis rather than sleepiness. So again, electrolytes, I believe Joseph told us that electrolytes are normal, so that's not an issue. So Joseph, what I'll say is considering my limitation in knowledge, so the exact things that I told you I had in mind are the exact things that are remaining. So narcolepsy, I would say a provisional diagnosis that I'm throwing for this patient is narcolepsy, and I will not make any efforts to determine the type of narcolepsy, whether type 1 or type 2, because I do not even remember what are the differences in those things. So that's what I have for now, and I'll just sit back and learn from whatever I'm missing in this case.
Yeah. Thank you, David. um, this patient walk. Uh, I don't know, but this happens. Patients come in, you realize they should be seen by PID, but they come to physician. There are reasons. So when they told me uh, excessive sleepiness, I say, no problem, because I've diagnosed the number of cases about narcolepsy as you're saying previously. And then when I listened to history, I realized this couldn't be narcolepsy, as I've told you in the HPI there. And then I realized I don't know this diagnosis, and I thought I'm missing in my approach to excessive sleepiness. I'm missing something. So I said I will go back and read. I told them I don't know anything. Maybe. So they say, Who should we see?" I said, "Okay, you can see uh, pulmonologist, because that's pulmonologist is also specialist for sleep." So I sent them to a pulmonologist. Then when I went back home and I read, I got the diagnosis. Too bad I went back seeing the system that there was no contact, so I couldn't call them back and tell them the diagnosis. We should have started management. So I don't know what is up, and other questions that we should have asked, as you see there. So David, I didn't have the diagnosis initially, and but later I realized there is this called Crane-Levin syndrome, perfectly fitting her presentation. But yeah, the problem is I couldn't tell them because I've lost. There are no contacts in our system. So let's see. If you see a patient with hypersomnia, the most important thing is to ask: Is it a problem? So how do you know? If patient comes in and they're complaining about it, then that's a problem. You have to solve it. Or when it interferes with their function, as in this patient, she was in boarding school performing well. She has to be told by the school, you have to go back and attend day school because you're sleeping too much. You cannot attend in boarding school. So that's a problem. And then there are lots of etiologies, as I summarize here. But the most important, David, and I can tell you, you might be waiting for the final diagnosis, but you could have listened the problem representation David put at the end. That's the most important thing, not even the diagnosis. If you take that word David was saying and put it in a search engine, Google, even maybe an AI search engine, the diagnosis will come there. This is that what I also did. The diagnosis was just then. Put it in Google, periodic hypersomnia, and it came. So inadequate sleep is the most common, but there are other sleep disorders like obstructive sleep apnea, obesity, hypoventilation syndrome. She was not obese. Central sleep apnea, restless leg syndrome, but also central hypersomnia, in which you have narcolepsy, Crane-Levin syndrome, and idiopathic hypersomnia. Other comorbidities can also cause hypersomnia, which include Parkinson, multiple sclerosis, hypothyroidism, as David told us, obesity, and others. And psychiatric diseases like depression, anxiety, and others can also present with hypersomnia. Meds, very important, like sedatives, antihistamines, anticonvulsants, antidepressants, and others. So there are tests to do. I don't think if they're done around here. Maybe if David know, you tell me. Polysomnography. This will diagnose obstructive sleep apnea, periodic limb movement disorders, narcolepsy, and seizure. Some patient might be sleeping too much because that sleep is a seizure, but not this patient. Others tests include what is called a multiple sleep latency test and actigraphy. I don't even know what are these. So let's see about these new diagnoses that I added in my brain, Crane-Levin syndrome. So this is also called recurrent or periodic hypersomnia. The definition is that there are recurrent episodes of severe hypersomnia which are associated with cognitive and behavioral disturbances. It lasts days to weeks, as in this patient, and then separated by weeks or months of normal sleep. So epidemiology is a very rare disease. Only 1 to 5 cases per million population, and more common in males than females. The cause still unknown, but it's thought to be a combination of psychologic issues plus things which happened around delivery, maternal infections, poor labor, stuff like that. But those are hypotheses. So I presented this because when I read, I realized, okay, it's not just a childhood disease. Maybe in the future, we'll see someone with same presentation, an adult who come in as internal medicine, and why I presented it here so that everyone could learn it, and maybe you see someone you can diagnose it. So the median age of onset is 16 years, but it ranges from 4 to 82. Anyone can get this. Child, adolescent, adult to old. Anyone can get this disease. But 80% will present during the second decade of life, like uh, 11 years to 19. The symptoms, episodic hypersomnia. So you get hypersomnia, you go back to normal. And then there is cognitive disturbance. I wish I could have called back this patient so that I could ask about the cognitive disturbance. I didn't have this. I didn't have this because I didn't ask it. I didn't know what was going on. And also altered perceptive state, like it is written that patients are saying they are seeing when they are in that episode, they are seeing or feeling things are not as usual. Like they see you talking, but you're talking maybe in a very low voice. They are looking at the environment and they're seeing like, am I new here? Is this our home, for example? Is this my bed? Like it's looking normal, altered perceptive state. And then apathy, disinhibition, mood disturbances, etc. They can also be there. The clinical cause, so the disease will self-terminate on its own, but the duration for that is pretty much variable. There are, in reported cases, there are cases that terminated just within 6 months, and others which went on for 41 years before self-termination. Um, Treatment during hypersomnolence is just supportive. So you educate the parents and the teachers. You tell them this is normal. Maybe it will go away on its own. But when this happens, you have to allow the patient to sleep. Like it's in the class, give the environment for the patient to sleep. If you don't, they start getting moods like they start being aggressive. Why are you preventing them from sleeping? They feel it's their right to sleep. So you allow them to sleep, and they wake up and continue the other stuff. But it's told in the literature that if it's too severe or prolonged periods, lithium or high dose glucocorticoid can be used. So that was our case today, David. If you have any reflection.
Yeah, thank you, Joseph. So I Klein-Levin syndrome. I'm not sure. I think even if I spent an entire day here, that wouldn't come up. So maybe, and thank you very much for bringing this up because I I think when we were still residents, I saw one patient, and again that was a young girl just like this one. And so what we were thinking of at that time was narcolepsy. So hers was more, it was not as brief episodes like this one. So what we thought of was narcolepsy at that point, and I think after that I have not had any encounters that I can remember of someone who is presenting with excessive sleepiness. I mean, in this sense, apart from people in whom you are suspecting maybe obstructive sleep apnea or other things. So that helped me think a bit harder and recall some of the things that can present with excessive sleepiness. So maybe Joseph, as I see there are some questions here. So this one is brain can brain stimulants like amphetamine be used in such a condition? So I'm not sure about what Joseph has been presenting, Klein-Levin syndrome, but for things like narcolepsy, there is a medication like modafinil. It's called modafinil. It's a psychostimulant in a way. Now I'm not sure if there are some variations of amphetamines that can be used, because we know amphetamines, people use them. I mean, they are drugs of abuse. So maybe there are some molecules, equivalents of those that can be used to maintain wakefulness in these patients. So one that I remember is modafinil, and I do not remember in which group of medications does it fall. So Joseph, maybe as while anyone who has any questions or comments raise up their hands, maybe do you mind reminding us the presentation of narcolepsy generally, because I do not remember it completely, and how it differs from this one.
Yeah. So first of all, we start with the Momax question. So the brain stimulants don't work in this Crane-Levin syndrome. Yeah. So the central hypersomnia, there are like three. The usual one that we know is narcolepsy, and now the second one here, Klein-Levin, and there is another called idiopathic hypersomnia. So if you don't meet the criteria for Klein-Levin and narcolepsy, you go into the idiopathic. So narcolepsy is not periodic; it's just continuous. And then you have the hypersomnia is the main complaint, but you have other stuff that I was giving up in the HPI, which includes, for example, sleep paralysis. For example, patient, the alarm goes up at 6 a.m. They have to wake up, but they can't wake up. They feel like they cannot move. They're sleep paralyzed. Or few minutes after sleeping, and then they feel like they cannot move their arm, but they are awake. So the way it is defined is that there are instances of wakefulness that interferes with sleep, and there are instances of sleep that interferes with wakefulness. So sleep paralysis is one, cataplexy is another. Cataplexy is like this patient when they're emotionally aroused, they lose like muscle tone. Patient is laughing or have an emotional encounter, and then they can fall down. They lose their tone and they can fall down. And the other three things, so cataplexy, sleep paralysis, and hypnagogic hallucinations. Um, just before waking up and just before going to sleep, they hallucinate stuff, a lot of things. It's so vivid. I've seen a patient with narcolepsy. If you ask this, like they say, "Oh my God, if like you were there, this is what I get." Yeah. So those three things. Like, so it is quite four: hypersomnia, cataplexy, hypnagogic hallucinations, and sleep paralysis. It's not periodic; it's just a continuous thing. And then when you see hypersomnia, which is episodic, the diagnosis Crane-Levin. When it is hypersomnia, those two things are not there. You have ruled out the secondary cause like ulcer, obesity, hyperventilation, and you see it's a central hypersomnia, then it's idiopathic hypersomnia. I think that's approach.
Yeah, thank you very much, Joseph. So, uh, yeah, so you see, that's why problem-based learning is, I think it's the best for me, because you see patients and you read about something, it sticks more. I've read about narcolepsy in the past, and see, when I was discussing here, I completely forgot about issues like cataplexy and others. So Joseph is reminding now, uh, hindsight bias at its best. So many times is, once you find out the final outcome, then things start making sense. Yeah, that's how hindsight bias works. So thank you very much, Joseph, for the good reminder, and for this education on sleep medicine. So we still have minutes. I see the chat was busy today. I got a lot of help, and some more differentials like trypanosomiasis from Roland, and then Antimon came up with something else, menstruation related hypersomnia. And so Joseph, as you were reading through, did you also come across something like this? Because I think is it an issue of narcolepsy or another sleep disorder where, yes, especially for young girls, they become more sleepy when they so during their menses. Did you come across that?
I know that would be a new thing. Maybe I have to check. I didn't see the relationship between hypersomnia and menstruation.
Yeah, so I have a very hazy memory of something like this. I do not remember if it's an isolated condition, but something to do with so for some they become hypersomnic during their menses. So maybe it's another thing that we need to check on. So the chat was busy, got a lot of help. Now in the remaining minutes, if there is anyone with anything, any questions, any comments, any experiences that you'd love to share, because yeah, these are not things that we see often. Someone coming with a complaint of excessive sleepiness. I think people attend patients with insomnia. Those are more common than people with excessive sleepiness. So if anyone has any experiences to share, any questions or any comments, please welcome. Yeah, I do not see any hands. So uh, we we almost had new discussants today. Unfortunately, they were both on the road. So maybe I think in the near future, either as a solo discussant or with me, I believe Amani will be ready to discuss, and then we have some other people. See, I got a lot of help from the chat, so I believe some other time Brendan will also be willing to discuss. Roland has discussed in the past, and so maybe in the future he would also be willing to discuss. So what we want is to learn from new people every time. So yeah, next week we meet again. So if there is anyone who is willing to discuss, please feel free at the beginning of the presentation. You can just raise up your hand and volunteer to discuss for that day, because you have a lot of knowledge and wisdom that we can benefit a lot from. So, and another thing, cases. We enjoyed a lot. Two cases back to back for 2 weeks from Michael. So anyone else in the audience who has any cases that you are seeing, please bring the cases so we can learn from them. Having said that, if there is nothing else, have a good night and see you next weekend.
Good night.